James.
Yeah, so I think I know most people here. My name's James Johnston, or Jimmy Johnston, most well known as, and I'm from New Zealand, so if you can't understand me, I'm sorry. Dr. Goldenberg has an excellent interpretation service. So my talk is the common man meets the lethal woman, and actually I discovered that the common man is a very popular cartoon character in India from a long-running, there's a statue of him in India. But anyway, yes, I could have put Donald Trump and Hillary Clinton. So my objectives for today were to explore the differences in, I guess, outcomes, but also the etiology and biology of bladder cancer between men and women, and identify possible intrinsic and extrinsic reasons which may account for that. So we're roughly going to run through this this course. So the reason that I chose this topic was it was something that I found interesting. I know that bladder cancer is common. It's the 9th most common cancer in the world, 4th most common in men. So and it's more common in men. And also, what I knew was that it seemed that women do worse. So I wanted to investigate a little bit further into why that might be. This is data from the United States looking at cancer incidence overall on the top, and you've got the male overall and female, and you can see the peak in the early 90s, which is due to our common friend, the prostate cancer. And you can see in the lower half is the mortality from cancer in the United States, and this is all cancers. And you can see that the higher level in men is mirrored compared to women. So when it comes to bladder cancer, this is a meta-analysis from 2009, and you can see all over the world this ratio persists. The triangles are the male to female ratio, which sits around about 3 to 4 on most studies. And you can see there's some variation, like in Polynesia and Micronesia. There doesn't appear to be any bladder cancer in females, which I can tell you is incorrect. The Northern America is somewhere in the middle there with quite a high rate of bladder cancer in men. So in general, women live longer, and they live longer with cancer. They do better with cancer. And this is true across most cancer streams except for bladder cancer. And not only that, this is true except for older patients, and that difference is primarily due, we think, to bladder cancer. And in an article in Urology 2000, women seem to do worse, stage for stage. So you would think that maybe the worst disease presentation is accounting for that. And if you look at the 5-year relative survival, you can see that this is broken down per stage. I don't know if it's come up there. No, it hasn't. So the graph hasn't quite come across. But down the bottom, it's grouped into stages. So the top is the top 2 are stage 1 or T1. The next is stage 2, T2, T3A. The third group is T3B and T4A, and the fourth group is T4B. Nodal or metastatic disease. So you can see that stage for stage, the females do worse on a relative survival. And probably just looking at stage 3, the T3B, T4A, you can see that the overall survival, or relative survival, is 58.8% for men and 49.6% for females. So looking at
Sorry, can I just ask you, if you compare it to like colon cancer or form of cancer which is roughly equally distributed, do you see the trend?
No, so across most cancers, all cancers, women do better, but not bladder cancer. So no is the answer to your question as far as I know. So this was a recent meta-analysis, actually in October, which and this is a table representing non-invasive bladder cancer. So it's a really heterogeneous group. But by and large, for non-invasive bladder cancer, most studies found either nothing or an increased risk of recurrence or progression for females in bladder cancer. What about invasive disease? Most of the information we have on this is retrospective review of large radical cystectomy data, and this is the largest and probably the most recent, which was in European Urology 2014, and includes a lot of bladder cancer patients from Canada. So over 8,000 patients, multinational, multi-institutional. And basically what they found was that there was some slight increase in stage at presentation for females. It's not huge. And when you controlled for the pathological stage and grade, the recurrence rate was actually not different between males and females, but the cancer-specific mortality was a little bit higher for females. And there was no difference in the number of nodes removed, lymphovascular invasion, soft tissue margins, and the use of chemotherapy. So why is this? So I wanted to break this down to extrinsic and intrinsic reasons. So we'll start with the intrinsic causes. So we know that smoking is one of the most important risk factors for bladder cancer, and globally the incidence of smoking is reducing for men and women, but the total number of women smoking is increasing, and the total number is thought to double by 2025. A little bit more local data, 20% of US men and 15% of US women smoke. So in a paper in 2011, the incidence is reducing, but it seems that the risk of smoking to bladder cancer might be increasing. So, and they're not quite sure why this is, but perhaps different constituents of the tobacco and the cigarettes themselves. In 2015, this group reviewed patients in two large screening trials, the lung cancer screening trial and the PLCO, which we'll come to in a minute. And the incidence of bladder cancer in these groups was higher in men despite the level of smoking. So under 50 pack years, over 15 years stopped. More in men, higher incidence in men. So this is independent of the level of smoking. And the same was seen in the PLCO trial when they looked at that too. This is an old paper from 1990 in the Cancer Institute, and they looked at thousands and thousands of people, and the squares are male and the circles are female, and so you can see that with age and being male, increased incidence of bladder cancer. The hollow squares and circles are patients who don't have non-smoking, and they don't have risk factor, occupational hazards or urinary tract infections. So when you remove those risk factors, the difference in men and women persisted. So this is something that is talked about, hair dye. So aromatic amines in hair dye are thought to contribute to bladder cancer, and these were effectively banned in the 1980s. This is a substance called PPD, which is actually white, but when it gets oxidized, it turns dark. And so there's been a couple of good case controls in Los Angeles and New England, which have shown that there is an increased risk of bladder cancer for women who use hair dyes, and this seems to be related to groups of patients who have problems with enzymes that degrade the toxins. And Dr. Black asked me about hairdressers. Well, hairdressers do have an increased risk of developing bladder cancer with I think it's a summary risk ratio of 1.7. And if you're a hairdresser for longer than 10 years, then that risk is even more so. This is the meta-analysis of the studies. They don't know, because of the long history, they don't know whether the changes in the 1980s, which banned some of the aromatic amines, will have an effect on this. So another risk factor that we sometimes talk about is recurrent infection. So We know that dysbiosis or altered microbiome in environments can cause cancer, and we see that with H. pylori, hepatitis, and schistosomiasis. And we think it's due to these 4 possible reasons. Chronic inflammation, high cell turnover, toxins released by the bacteria, virulence of the bacteria, or potentially metabolizing compounds that may then become carcinogenic. So there's quite a bit of data, but it's not that good, and so a retrospective review of all of the published literature, the relative risk of about 1.4 to 1.6 with any urinary tract infection, and a large case control study in the 1980s showed that 3 or more urinary tract infections increases your risk by 4.8. But they're not sure. This might be patients with bladder cancer might have a recall bias, is one possible explanation for this. There's a group who in 2014 did PCR of 16S ribosomes used to identify bacteria and culture negative urine. And what they found was that in men compared to women there was a difference. So lactobacilli predominance in women and Corynebacterium predominance in men. So, and other studies have shown that lactobacilli may have a protective role in bladder cancer. The issue with this type of study is that there is obviously a risk of contaminants in the urine, getting the urine from specimens, so you're getting a really highly sensitive test. So to be aware of that. So in general, the toxins to the bladder, these are the 3 main ones that I found, and so N-acetyltransferase number 2. If you're slow with that, then the hair dye seems to be a risk factor for you. This UGT1 seems to be under endocrine control, and GTSM. I don't know actually. I should say actually about that hair dye, what they found was that, and I didn't mention it, it was permanent hair dye and women with a college degree, and so they think that the college degree infers some sort of affluence, so that people who are dyeing their hair at home maybe don't have the same risk factor as those who get the hair dye less frequently at the hairdresser because it's a stronger dye, and maybe there's a recall bias. It's all speculative.
But I thought aniline dyes were more associated with superficial disease. And this is all going to be that. Do you know, is there a difference between invasiveness characteristics of?
I don't know. I didn't find that.
Dyes versus invasiveness.
I didn't find that. No. So looking at this is probably one of the most important and well-known reasons for difference between men and women. And so this was a review of nearly 30,000 patients between 1992 and 2002 on the SEER database. And this is for delays in the diagnosis of bladder cancer and what that might mean. And so cancer-specific mortality and all-cause mortality, even adjusted for stage and grade, if it takes longer to diagnose the bladder cancer, there's an increased risk of mortality. So, and this is we know this is true, and so this is important, and this is what we think happens to women. And so there's been a number of studies. These guys in 2014, they reviewed the insurance plans retrospectively. There are 100 health insurance plans from 40 large employers in the United States. And what they found was that the number of days from the hematuria to the diagnosis was longer for women, not hugely so. And a delay of over 6 months was more common in females compared to men. And as well as that, women were more likely to be treated for a UTI, and they were less likely to get abdominal imaging as workup for the hematuria. In 2013, Henning, this is an Austrian group, and they sent out questionnaires for patients waiting for TURBTs, and what they found was that women were less likely to consult a urologist. They were more likely to consult a family physician or a gynecologist compared to men. They were more likely to have symptomatic treatment for bladder pain or functional bladder problems. And they were more likely to have been treated for had 3 or more treatments for urinary tract infections over the preceding year between the diagnoses. And another study also confirmed these similar delays. So then I wanted to look at the differences in treatment. So in general, the treatment strategies for men and women are the same, and they don't differ. And radical cystectomy radiation therapy are offered equally amongst men and women. But in more recent times, this has been somewhat questioned. Looking at endoscopic treatments, there was a review of TURBT cases, over 1,000 cases, and they found that being a female or being obese gave you an increased risk of bladder perforation. Most of these were extraperitoneal, as you would think. And the reasons that they conclude is that women have thinner bladders. Now, I don't think anyone's actually measured the bladder wall here, but it's something that we know is when we do a transurethral resection of bladder tumour, especially the ones on the dome, it's something that we certainly worry about. Women seem to more frequently receive BCG, although this was in a Spanish study, and relatively small numbers of non-invasive disease. And this is a large group of patients from the Memorial Sloan Kettering looking at the differences in radical cystectomies between men and women over a 10-year period from 1995. And so women had higher comorbidities. They were more likely to have had previous surgery. They had slightly longer operative time, slightly higher blood loss, and they had slightly more complications. So the node dissection is quite interesting here, that an inadequate node dissection performed in 90% of women compared to 96% of men. So the reason that they postulate that this occurred was because a lot of the women had had prior surgery, including hysterectomy, oophorectomy, where node dissections may have already been undertaken. And so looking at that's the treatment side, and then what about the response to the treatment? So this is a meta-analysis of nearly 28,000 patients involving 17 studies. And when they looked at the hazard ratio, it was 1.2, and that was even when tumour stage and grade was accounted for. So similar to that paper in 2000 that stage for stage, women do worse. This is similar. So this is the same paper that we talked about earlier. That's over 8,000 patients, multi-international, multi-institutional, and this is, I think, an interesting graph in that the orange lines are the mortality from cancer following cystectomy, and the blue lines are mortality related to other causes. And so the solid line is female and the dashed line is male. So women seem to do worse after radical cystectomy, but men do worse for other reasons. And so what they found was that women don't necessarily recur more frequently. It was not significant, but there was difference in overall mortality cancer specific. So it seemed that those who do recur do worse in females, indicating that there might be a problem with the biology of the tumour as well. These findings are not universal, and this is a study from the University of Southern California, and these patients were very well matched, 414 females, 414 males, and they were matched 1-to-1, and they were balanced for many things. And what they found was that there was no real difference to blue and red, male and female, for cancer-specific mortality or overall survival. And these patients, some of these patients were from the 1970s, so it's long follow-up. So then I wanted to talk about intrinsic reasons why these differences may occur. So genetics, tumour biology, anatomy, and endocrine. So with regards to genetics, and I'm sure there's plenty of people here who could talk about this antigen more eloquently than me, but prostate stem cell antigen on chromosome 8 has an androgen responsive element, and this group has found that the SNPs on this area may have a role in bladder cancer. It's speculative. This is, I think, quite an interesting area here, tumour biology. So recently, a number of groups, including the TCGA, have subtyped bladder cancer into molecular subtypes based on biomarkers on mRNA. And so similar to breast cancer, there's a number of different groups of them, but more or less you can divide them into sort of a basal subtype and a luminal subtype. So the basal subtypes of bladder cancer tend to be more advanced. They have sarcomatoid features, they have squamous differentiation, and they're similar to basal breast cancers. Luminal, on the other hand, have a better prognosis, and what's interesting is that they have estrogen receptors predominantly found compared to the basal features. And this is and you won't be able to read this, but MD Anderson's group also looked at this and grouped them into 3 groups, the basal, luminal, and P53-like. But I want to highlight particularly one part of the table, and that's the female and male difference here. And you can see that overall about 26% of patients were female, and this is only 73 patients in total. But they seem to be overrepresented in the basal subgroup with 44% versus 57%. And in the luminal, there were only 13% were female. So it seems that maybe females are overrepresented in this basal subgroup. And when you look at the overall survival, this basal group do worse. So now I want to look at anatomical differences, and we've already sort of talked briefly about the thickness of the bladder wall, and this group, although they haven't really measured the bladder wall thickness or anything, they have theorized that a thickened bladder wall is somehow protective. Another group with an anatomical pathological studies found that cancer cells seem to spread in these periurethral lymphatic channels, and their theory is that the prostate may have some sort of protective role there. I think at this point it's important to raise the issue of T4A. So in bladder cancer, we stage it just like everything else, TNM, and T4A in the male it's into the prostate, and into the female it's into the gynecological organs. So these are not necessarily the same disease, and this may and others, and this was a German group looking at over 2,000 patients, found that females did significantly worse, and this was repeated by Aziz and Shariat in the BJUI when they were looking at forming nomograms, and for T4A, being a female, is an independent risk factor. And that hazard ratio was 1.45. So I think T4A is a particular group that, there are some anatomical differences, and it appears that there is significant survival differences. So what's underlying all this? And I guess when I was doing some reading around this, my theories were that does somehow the androgens promote bladder cancer and estrogens protect against bladder cancer, but maybe estrogens predispose you to a more aggressive form? I'm not sure. So looking at the androgen receptor, a lot of this work has been done in animal studies. So they have these mice which are tumour forming, and they they castrate them, and they reduce their chance of getting tumour and tumour volume. Then they've got mice that have androgen receptor knockout, and then they gave them a carcinogen, and if you do not have the androgen receptor, if the mice didn't have the androgen receptor, then there was a much less chance of developing bladder cancer. In humans, in more recent times, I think this was published in April of this year, this group looked at the PLCO trial, and so they looked at patients who were on Finasteride. So overall, just over 8% of patients in the PLCO were using Finasteride, and at 13 years, the risk of developing bladder cancer was less, although low in general.
I love curves like that. Y-axis.
Oh yeah.
Yeah.
And so this would fit with the idea that androgen somehow promotes bladder cancer. So I wanted to look at their data a little bit closer, and I found the data, and in terms of the grade, although this didn't reach statistical significance, there was a tendency to have higher grade in the patients who had the Finasteride. I don't know if there's anything in this, but I thought it was interesting.
I was only say that. I think that thought there was some data that AR antagonists had activity in some AR positive bladder cancers. In some model systems.
Yeah.
So I think you have to include that in this kind of extrapolated.
Yeah, sure.
Data.
So, looking at the androgen receptor further, this is there've been various findings on this, and so this group in 2004 found that androgen receptor was present in about half of the bladder tumours, and interestingly, they found that there was an inverse relationship with androgen receptor and invasiveness, so that in non-invasive disease, 75% had androgen receptor, and in invasive disease, this was lower at 21%. And another group found that 5-alpha reductase was found in bladder cancer, and when in higher staging grade, this seemed to be lost. So estrogen receptor. So estrogen receptor comes in two forms, the ERA and the ERB, and then the ERB is thought to be the predominant receptor in bladder cancer. And a high level of estrogen receptor B is thought to be infer a worse prognosis. And it's not entirely clear why this is, but it may relate to this detoxification enzyme UGT1, and so that ERB downregulates UGT1, and then therefore higher toxin levels, and then there's a higher and there's been higher mortality shown with lower mortality shown with higher levels of this enzyme. So the theory being high ERB leads to low UGT1, leads to higher mortality. And so people have looked at tamoxifen, again, animal studies, and they gave and these mice, they gave them a carcinogen, nitrosamine, and then they gave them tamoxifen, and tamoxifen reduced the chances of them developing bladder cancer. So, in summary, I think that men do have bladder cancer more commonly, and it's not entirely due to smoking or other toxin exposure. I think women probably do worse, and a large part of that is due to delayed presentation and advanced stage at presentation, but I don't think it's entirely due to that. And I think, as we all know, men and women are intrinsically different in bladder cancer too, and they respond differently to extrinsic factors. And I think in terms of what this means is, we're moving sort of this protocolized medicine, and then there's precision oncology. And so are we going to get this situation where we've got ER status, PR status, AR status, CHEGI status, HER2 status, etc., etc.? And how are the guidelines going to adapt to that? Is there going to be therapy to target receptor status, endocrine manipulation? And I just want to end with some shameless promotion. So this is Taranaki. It's a surfing mecca in New Zealand. It's the second best place in the world to visit, so come and visit. No, that's our Mount Fuji equivalent, but yeah, it's a volcano, and it's in the northwest west part of the North Island. And just saying, Ed.
I heard you lost to Ireland.
Yeah, we did. Yeah, we did. But yeah. Anyway, thank you.